was saying, under those mixed action drugs, mixed action sympathomimetics, I was talking about ephedrine. You can see it there. You see ephedrine there? Yes. Ephedrine is a very important drug, very common. Sometimes it's formulated in such a way that you can use it as nasal drops. You drop it in the nose, and it helps in decongesting. It's a decongestant. When you're feeling your nose are so stuffy, like in allergic reactions or a flu, ephedrine has been used a lot. It's there even when you go to the market and you want to buy it, you can have it. And because it's that common and it's something that you can easily access, then I would like you to know it inside out. So do some write-up on it. So the stories that follow are just general stories, which we already know. When you talk of bronchodilators, we have already mentioned. I want to also insist on one there, and terbutaline. Terbutaline is common in the name of Ventolin. Ventolin. It's again used a lot of times in asthma. We have it, we use it for nebulization. It's also there in some inhalers. So I would like you to remember it. Okay. When we say a drug is an what do you mean when you say a drug is Hello?
Yes.
I'm there on that slide. Are you seeing slide 3 or 9?
You are not sharing.
Oh, I'm talking. Okay. The good thing is that you have the slides, but it's good we flow together. Are you seeing that slide?
Yes.
Bit of anorectics is the one I wanted to say about. What is when we say a drug is anorectic, what do we mean? Hello? What is an anorectic drug? We know a condition called anorexia nervosa. Anorexia nervosa.
Yeah.
Yes, yes. How does it manifest?
With loss of appetite.
Loss of appetite. It's quite often, especially in young ladies who are so conscious of their figure and maybe stressed about to reduce weight. So they don't eat. Actually be used for that purpose. But please, I'm not advising anyone to go that route, because you can have a drug that looks like scientifically it can do so, but then clinically we don't know the other effects. Okay, but reduce appetite, and therefore they will reduce food consumption. Good. Say, what are you? Hello?
Yes.
You seeing the slide there?
Yeah.
Are you seeing the slide?
Yes.
Yes.
Munaona?
Yes.
Okay. I wanted just to mention what COPD means. COPD idea?
Chronic obstructive pulmonary disease.
Chronic obstructive pulmonary disease. Very good. So what are some of the diseases that form that spectrum of disorders?
Bronchitis.
Bronchitis, emphysema, and bronchitis,
There are only
emphysema. Yeah?
There are only two.
There are more. Bronchitis, emphysema, and are you able to? We can proceed, I hope. So I was saying chronic are not only two. We have bronchitis, we have emphysema, even chronic. Okay. So we have seen that these drugs are also important there. Isoproterenol, those are just but the examples that we have already mentioned. So the rest of the stories you're going to read by yourself. Those are just
The network is very poor.
my network.
Yeah.
Okay. What will call interfere? I've not been talking. I was actually just going through the slides to see which ones to speak about. Just confirm that you can be able to see that slide.
Yeah.
Okay. So when we talk about agonists, we have what we call alpha-1 selective agonists. Alpha-1 selective agonists. Which means they are working mainly what? On the blood vessels. On the blood vessels. The key among the purposes we use them for is this one. Used to manage hypotension and shock. Why do you think they are beneficial, these alpha-1 agonists, in managing hypotension and shock?
I think they cause vasoconstriction, leading to increase in blood flow. Yeah.
Okay. Because hypotension is actually low blood pressure. Okay, you can still hear me?
Yes.
Okay. So when we use these drugs that increase the tone of the blood vessels, they constrict, then the pressure will actually increase. How do you usually define shock? How do you define shock? Pressures. We define shock. Okay, sorry. You're speaking. Kindly go ahead.
Shock is a condition where there is inadequate tissue perfusion and oxygen delivery.
Very good. And the original problem being what? Why the inadequate tissue perfusion?
Ischemia.
Ischemia is the outcome, is the consequence.
Oh.
Now, the original problem we don't know, but one fact is the cardiac output is low. The cardiac output is low. If the cardiac output is low, then tissue perfusion will also be low. But there might be other causes that now contribute to the cardiac output being low. Either one has bled, hemorrhagic, either one has not taken enough fluid, either one has vomited so much or has had diarrhea, had a lot of sweating, like in exercise, all of those. Or one has what we call distributive shock, or maybe the heart is failing, cardiogenic. End of the day will lead to low tissue perfusion. When we give this pressure, increase the heart rate, they increase the tone of the blood vessels, and therefore but this particular one, alpha-1 agonists, selective alpha-1 agonists, will work mainly on the blood vessel. Okay. So examples are there. Phenylephrine, kindly read about that and make drug cards on that because it's one of the most common ones. It's also there in some of the cough formulations as a decongestant. There are the others. Then alpha-2 selective agonists. Alpha-2 selective. We said alpha-2 is where?
Blood vessels and platelets.
Blood vessels and platelets. Still, the effects are the same. It's only that it will be selectively working on alpha-2 receptors. And we have the examples of clonidine, apraclonidine. Among these, the one that is commonly used, and I'll ask you to write drug card about it, is clonidine. Write about clonidine. Then we have miscellaneous agonists like ephedrine is also there. Okay. Now let's look at adrenergic antagonists. Adrenergic antagonists. We have seen the effects of adrenergic stimulation from the pupils, in the airways, on the heart, in the GIT, on the uterine smooth muscles, on the kidneys, on the cardiac and urinary sphincters, and so forth. Now, if we block those effects, what do you expect? When we block adrenaline effects, what do you expect on the eye pupils? When we block adrenaline effects, what do you expect on the eye pupils?
They constrict.
They constrict because adrenaline makes them open, isn't it? Good. When we block adrenaline effects on the respiratory apparatus, do we improve patency or we make them narrow?
We make them narrow.
Make them narrow.
We make them narrow. So we reduce the patency. When we block sympathetic effects on the heart, do we increase the force and the rate of heartbeat, or we reduce the force and the rate?
We reduce.
We reduce of the heartbeat. When we block sympathetic activity on the GIT, secretions. What happens to the GIT secretions by blocking sympathetic activity?
It increase.
Hello? Songoro, you are speaking. Kindly go ahead.
Okay, they increase.
Natasha, kindly just take it.
The secretion increase.
The secretions increase. Good. What will happen to peristaltic?
Peristalsis increases.
Good. What will be the effect on the uterine smooth muscles?
They contract.
Okay, good. So once we know those effects, then the drugs are just going to give us those effects in variable amounts. And that will be it. So the rest will be pharmacokinetics and pharmacodynamics of the drug. But as to the mode of action, we know the receptor block which receptors. It may block alpha 1, block alpha 2, block beta 2, or block beta 3, depending on where the drug has affinity for. And once we know the receptor it blocks, we already know the effects that follow. Okay, let's see the examples. We have alpha receptor antagonists, either reverse alpha receptor antagonists. So let's talk briefly about alpha receptor antagonists. What is the effect of alpha receptor antagonists? In other words, what physiological parameters will be affected when we block alpha receptor? What physiological?
Blood pressure.
Very important, blood pressure. Okay. So once we constrict or dilate the vessels, we affect the reduction or increase. Hello?
Yes.
Alpha 2 blockade on blood pressure. Hey, just infer the stimulation causes vasoconstriction. So when we block alpha 2 stimulation, therefore, are we promoting vasoconstriction or we are promoting vasodilation?
Promoting vasodilation.
Vasodilation.
Good. And what is the effect of vasodilation on pressure?
Reduced blood pressure.
Reduce.
Reduces blood pressure.
And we utilize? Good. In which clinical situation then can we utilize alpha 2? Because when we dilate the blood vessels, then we are going to reduce the blood pressure. Look at that. Example, phenoxybenzamine, others, terazocine, prazosin, doxazocine. So the rest of the pharmacokinetics and pharmacodynamics you read. Okay. I want us now to go to the next category. Beta adrenergic 1 block. 1 adrenergic blockers. What is the effect of blocking beta 1 adrenergic receptors? What is the effect of blocking beta 1? Where was it abundant as we looked at it that time?
So it was abundant in the heart muscles. So I think when we block, we will
Yes.
result
Reduced,
in reduced heart rate.
and contractility is also reduced.
Good. Very important. So if somebody is having things like tachycardia or arrhythmias, we can actually reduce. Can it also be useful in high blood pressure?
Of course, yes. Yes.
Good. Okay, so let's look at we are having drugs like propranolol. Hello, are you able to hear me?
Yes.
Kidogo hapa network yangu inasumbua tena.
We are not getting you.
Okay, sorry. Are you able to hear me well now?
Yes.
Okay, sawa, sorry. Hapo nilipotea kidogo when people call, the hotspot gets interfered with. So we have seen what blockade of beta 1 and do a reduction in the heart rate. It will make reduction in the force with which the heart beats. In tachyarrhythmias, we can utilize these drugs in tachyarrhythmias. Okay, beta, we said beta 2 are plenty where?
In the
Beta
heart,
2 in the heart. In the heart or in the lungs? In the
in the heart and in the bronchi.
beta 2 are plenty where? In the airways, isn't it? Okay, so when we block beta 2 in the airways, what happens?
They constrict.
Constrict. Is there any situation in life that we would like to constrict the airway? Is there any one moment, any situation that will demand us to try and narrow the airway?
I guess there must be.
Situation at all that would require to reduce the airway. In any case, we want to open oxygen and remove the carbon dioxide quickly. The benefit of knowledge of this knowledge is to know the of using this kind of drug in persons with why? Propranolol can be good in managing tachyarrhythmias, but then you give it and the person has asthma. What will be the consequence of that? There will be one benefit, but there will be another problem. What will be the benefit? What will be the problem?
The benefit will be reduced contractility, and the problem will be that the bronchi and the airway will constrict, hence not enough air will be entering.
Hence worsen the symptoms of asthma. Okay? So it will be a mistake to give this kind of drugs to an asthmatic patient. And that's the time when you give them and you are sued, and you are sued for negligence, then it is likely to be a valid case.